right, I will get started, and I'm going to be heavy on the CAR T here, which makes sense with what I was speaking about. So the first question: can you simultaneously use CAR T if you're on Ocrevus, or do you need to come off prior to CAR T? That is a great question. So things like Ocrevus suppress those B cells. So if you don't have B cells to target, it's not going to work. So you need to be off of any B cell agent before enrolling into one of these clinical trials. The typical washout period is 6 months. That's just how it's redosed. But in reality, the best way to do that is measure those B cells in the blood, so you make sure that you do have something to target. Each protocol is going to be a little bit different in terms of how they measure that and what their strict criteria are, but the protocols that I have seen have been around that 6 months.
So one of the cards I had gotten was Dr. Alvarez had talked about the new criteria for MS, and if you don't meet those new criteria, are you going to be undiagnosed? No, I don't think we're going to be undiagnosing anyone. The new criteria are complex and complicated, but if anything, they should be expanding kind of the diagnosis. And so in people where we weren't sure or who maybe didn't meet the criteria initially, but then later on met that, it's a guide to try to help with getting people a diagnosis earlier so that you can make sure you're doing the treatments or monitoring sooner than you would otherwise. Granted, we still don't have all the information on that, and Dr. Alvarez said that it took him a while to try to condense down those slides from what was presented, which was not the most straightforward presentation at ECTRIMS, but hopefully we'll be able to say more about that and probably use it more for when we're evaluating people for the first initial diagnosis of MS.
Great. I'll keep going with the CAR T theme, and I'm going to try to tackle a few of these actually at once, realizing there's a lot of overlap. So why does CAR T target CD19, whereas Ocrevus and other monoclonal antibodies target CD20? That is a great question, and I did not get into the nitty-gritty parts of the immune system and how that B cell progresses in its lifetime on my slides. However, your B cells basically start out as a they start out as a stem cell, go into a naive B cell, and eventually grow into a plasmablast. And depending on that life process, or that where you are in the B cell lineage, you can have those protein targets of 19 or 20. 20 is more restricted, 19 is a little more broad, so you're getting more early as well as more late B cells in their lineage. So CAR T does a broader target of those B cells. There are drugs out there, monoclonal antibodies called inebilizumab, that has FDA approval for something called neuromyelitis optica, which is a different type of autoimmune neurologic disease that can sometimes mimic and look like MS, but it is not approved for MS. So we do know those CD19 target drugs hit that B cell pathway a little more broadly and have this theory of working a little bit better. However, perhaps may have some more immune suppression. The more you target, the more you suppress in terms of your B cell lineage, the more infectious complications may come. And that gets into the next question here: how does CAR T impact the patient's immune system, and what is the risk for infection compared to the monoclonal antibodies? So with all of these things that suppress the immune system, infection is certainly a concern. The problem is the risk changes between the two depending on the timeline that you're looking at in the treatment process. So your CD19 CAR is going to be more immune suppressing at the time it's working. However, when you look at someone that's on Ocrevus or rituximab over the course of, say, a decade, that immune suppression is ongoing. Unlike the CAR T, where you're going to have a lot of immune suppression up front, That is why we watch, part of the reason, as well as other side effects, watch patients in the hospital for 10 days, and there's this high-risk period of 28 days where we watch you very closely until all those other B cells come online, and then you start making more antibodies. So that's more immune suppression in the short term compared to just long-standing immune suppression that's ongoing. And does the patient need to be in isolation after CAR T? When this process happens, you're admitted to the bone marrow transplant hematology service, so there is some inherent isolation that comes into play with that 10-day stay in the hospital. I'm going to stop there.
I'm sure you could talk much more about that too. So I wanted to go with a couple questions that were submitted before the sessions. I think are great. So one is how to educate friends and loved ones about MS in ways that they can help. And then a similar one, how to deal with my own expectations or resentments with family or friends who seem disconnected with my MS struggles. And when I had talked with Dr. Bloom, and there's a little bit more on this on the full interview, but this was one of the things that she wanted to highlight or talk about the most, that she was kind of most interested in sharing, because that's something that she struggled with too. Like she's a doctor in autoimmune diseases. She's a great clinician and a researcher and a friend, but like trying to explain that to people, even to her husband, is difficult. And even then, like, especially for the invisible symptoms, like it seemed there's kind of a balance on how much she wants to share versus not share. So I don't know that I have the answers for that. I think probably the best way is to seek out other people who have MS, and hear what their experiences have been and how they've worked with their family, their friends. If your family and friends are open to it, maybe looking at some of the resources from the Rocky Mountain MS Center, helping them to at least learn about some of the things that come up with MS, maybe some of the invisible symptoms too. I think this was mentioned earlier, but the young professionals group network, that's been great for some of my patients who've done it, just to be able to share their experiences with other people who intuitively get it. And you don't have to go through the same explaining that you may have to for other people.
I feel like I'm going to sound like a broken record by the end of this. All right. Can you target multiple immune diseases at the same time with CAR T? The way the CAR T trials are set up right now and the target that is being used with CD19, the answer is potentially yes. This is not something that, these trials are not enrolling patients on purpose with multiple autoimmune diseases, but once you have one autoimmune disease, you're at risk for others. And so I think we're gonna start to learn more about this. I am heavily involved with the STIP person CAR T therapy clinical trial that's occurring here on campus, and it's a CD19 target, just like the exact same target, there's actually one that's an identical molecule that's being used for multiple sclerosis. And so once you use that target, because it's just targeting the immune system, you probably have the ability to affect all autoimmune diseases, not just the one that you are using the CAR T for. We're going to learn more about that. So stiff person syndrome is a disease that causes neurologic disease, but it goes along with a GAD65 antibody where we can see type 1 diabetes. We can see pernicious anemia, which causes B12 deficiency, and a lot of those patients have those syndromes. So we're going to learn really quickly if we're impacting those other autoimmune diseases as well. One of the other questions here is, what are the criteria to join a CAR T trial? It's protocol dependent. So there's several different sponsored clinical trials out there. And so each each trial has a slightly different protocol. So depending on the individual, you might be leaning towards one protocol over another. I put on the slides that, again, I think you have access to it, the clinicaltrials.gov, so you can look at the different things out there, but it's very medical heavy. If you're a local patient, obviously reach out to our research team here, and we're happy to talk about what we have going on at the University of Colorado. One of the trials that we're involved with is with BMS, and that is a CD19 CAR T. And we are collaborating with CBCI, the Colorado Blood and Cancer Institute, on that particular study. And right now we're actively recruiting for relapsing remitting MS. There is an arm in that study that includes progressive disease. However, just based on how these protocols are set up in terms of FDA oversight and safety monitoring, the relapsing remitting arm is starting first. Once a certain number of patients are enrolled and safety can be evaluated, then the arm for progressive will open up after that. But there's a lot of fine print in terms of what makes you eligible based on what that progression looks like, how many relapses we're talking about, what other therapies have you been on, as well as there's many exclusion criteria. And I think there was another question somewhere of, what things are tested and how do you know you can do one of these trials? There's a lot of stuff that goes on to making sure it's safe to move forward, making sure you don't have a heart problem, making sure you don't have a lung problem. So things like echoes and EKGs and potentially pulmonary tests where we make sure your breathing is good. All of that has to happen up front in the screening before moving forward. And these are studies that require a lot of testing and, are a lot of time for participants.
So one question from the cards. Dr. Shaw mentioned remyelination. Is this a thing that happens now? And last I heard, we didn't know how to remyelinate our nerves. So remyelination is a thing that happens now. So after you have had a flare of MS, steroids are used to try to stop the inflammation, to start to turn that around and start to limit that inflammation. And after that happens, your body is working to remyelinate. So a lot of times you'll notice kind of right after starting steroids, a big improvement in symptoms, and that's the inflammation calming down, allowing the nerves to work a little bit easier than they were before. And then you'll notice this slow improvement over time, over weeks to months to sometimes even years. And that's your body remyelinating or kind of finding new connections. And so your body is able to remyelinate to some degree. A lot that we don't know how to do the best right now is how to enhance that remyelination. So, diet, exercise, using those nerves, that does help, as Dr. Alvarez, I think, mentioned earlier in the Q&A, that helps to to encourage those cells to start remyelinating, to kind of focus the remyelination efforts there. A lot of the medicines and other things that Dr. Alvarez was saying, haven't panned out yet, but are still in the works, are ways to try to enhance that, to maybe increase the time period that remyelination is happening and allow it to happen for longer, or maybe allow that to happen in areas that were injured years ago. And that's what we don't have yet. A lot of the other things are the things that we've talked about, like the exercise, diet. Starting a disease-modifying therapy doesn't help accelerate that to a big degree, but it does help make sure that there's not baseline inflammation that your body is kind of fighting against as it's trying to have that.
On here on time. So I'm going to pivot and not talk about CAR T, but another semi-related process. So stem cell therapy. There was a few questions about providing updates in stem cell therapy and where are we with that. So I gave that talk actually, I think either one or two education summits ago There is a randomized controlled clinical trial in hematopoietic stem cell transplant in multiple sclerosis that is still enrolling, is still ongoing. It's supported by the NIH, and it's a multi-center study looking at hematopoietic stem cell transplant versus high efficacy therapies. It's an incredibly difficult study to recruit for. It is called Beat MS. So if there's any interest there, you could look that up. I don't have an answer yet. Hopefully the answer will come from that clinical trial of where we are with stem cell therapy. If it is better than highly efficacious disease-modifying therapies. You can think of hematopoietic stem cell therapy very similar to CAR T, where you're really trying to reset that immune system. I think the interesting thing here is in the crossroads that we're at is if CAR T therapy and these clinical trials are successful MS, where is the role for hematopoietic stem cell therapy in the future? Because certainly while CAR T has a significant amount of risk, I would see it as still a much lower risk than hematopoietic stem cell transplant. That being said, CAR T is very targeted at the B cells, which we believe to be very important in MS, but you still are missing those T cells where the more broader approach with stem cell therapy is you'll hit kind of more broadly the immune system. So exciting research right now, still a lot of unanswered questions, but as these clinical trials recruit, enroll, and read out, hopefully we'll have some better answers in the future.
So I wanted to speak to a question that was submitted before. Why are symptoms required to last at least 24 hours before they are characterized as MS symptoms or exacerbations? And this gets a little bit to not so much, are they MS symptoms? Because as we talked about, you can keep having symptoms from the MS even when you're not in a flare or an exacerbation. But it's more kind of a way for us to help decide, what might be symptoms that are from active new inflammation and what are symptoms, unrelated to that. So when there's a new active inflammation, like a new flare, new demyelination, that usually takes time for that to build. Like it takes time for the fluid and the inflammation to build, and then it takes time for that to go away. Even with steroids, like that usually doesn't disappear within a day. And so when we think about flares or inflammation, like new things that will show up on the MRI, those will usually take days, weeks, months, kind of to reach a peak and then come back down again. So we've all had times that we've sat on something the wrong way and something started tingling, or for people like I was talking about in my talk, for people who've had inflammation in the past that's caused numbness or tingling, like in times when your body's under physical stress, emotional stress, you might have those symptoms come back. Usually those are things that will last less than 24 hours, and those will have kind of very different treatments than when we suspect that they might be like new inflammation and doing MRIs. Otherwise, people might end up doing a lot more MRIs or end up doing a lot more steroids than would be helpful for them. So it's not so much that those aren't MS symptoms, but it's trying to figure out what's new inflammation and what's things that we should look at treating in a different way.
All right, I am going to talk about next the link between autoimmunity and MS. So I just focusing and thinking about the immune system a little bit, it's very common to jump into this dogma of, oh, there's an autoimmune disease, your immune system is overactive, and that's why you're having problems. It's actually a lot more complicated than that. When you see autoimmune disease, it's actually a dysfunctional immune system. And so we can see even patients with an underlying immune deficiency, whether that's hereditary or acquired, such as HIV, you can actually see more autoimmune disease in those populations as well, because the immune system is just not functioning properly. So once if you swing onto the side of the spectrum of, think about it like this. If everything is in perfect alignment, you're in a nice center meter. If you're immune deficiency, you can have problems and you can develop autoimmunity. If your immune system is too inflammatory and overactive, you can run into problems. And so you really want to be in that perfect alignment. Whatever it is, the underlying triggers that takes you out of that alignment, whether it's an underlying immune deficiency or overactive in one area of the immune system, that can lead to autoimmune disease. And the immune system is messy. Once you have one autoimmune disease, you are at risk for others. And so that also includes multiple sclerosis. It's not terribly uncommon that I see patients in my clinic that have MS as well as rheumatoid arthritis, or MS as well as celiacs. So we definitely see an overlap of these autoimmune diseases.
There's a couple questions from online that had been kind of focused on treatment of symptoms or different symptoms in MS. So one was asking about chronic itching and if that was related to a symptom of MS, and then also, how to improve neuropathy, treating pain, and muscle relaxers for pain when sleeping. So to kind of answer all of those, so chronic itching can sometimes be seen, so that sometimes that can be kind of neuropathic, and so we might see that, although I feel like I've seen it kind of more rarely as like a symptom kind of after someone's had like numbness or something like that from their MS previously. And instead of having the pain, it shows up as more itching. And so sometimes our nerve pain medicines like gabapentin or some of the other ones that I had listed up there, sometimes those can be helpful for that. There's other causes for itching though, and so making sure that those have been looked at as well to make sure it's not just using the wrong medicines for it. In the same way, like those other medicines can help with helping for some of the nerve pains in MS. Nerve pains tend to be more burning type pains than achy or tightness or those. Sometimes achy or tightness can be from having some weakness on one side or the other, so your body's out of balance. Some of your muscles are kind of overactivating, being overused, and that's causing spasms. Sometimes it's related to the nerves themselves kind of being overactive, and so kind of compensating, increasing the tone of one of your extremities and kind of causing more spasms there. And so depending on kind of what type of pain it is, and depending on when it happens, like there's different strategies for that. So for the person who had asked about muscle relaxers helping with pain at night, I have had some people who've had benefit, especially if it's that kind of spasm type pain happening at night, that muscle relaxers can help with sleep and with relaxing that. And that type of pain can also sometimes show up most at the end of the day because you've been doing things throughout the day. And so being able to use that helps to relax the body again from its use throughout the day.
Or do you have a preference?
I don't. Do you have any more CAR-T that you wanted to talk about?
Just really quick, someone asked, I can answer this really, really quickly. There's just so many good questions here. It's hard to choose. But quick answer, someone asked about if you had MS for 30 plus years and advanced secondary progression, is CAR-T an option? Unfortunately, that's the conversation where we're talking about the holy grail of remyelination, because once that damage is done, intervening with something that affects the immune system might not be as advantageous. However, it built into the protocols for what defines that progression. If the progression is rapidly changing over the course of 12 months, that might be a different story. So I would just talk to your neurologist, reach out to the research team and see what makes sense for you as an individual.
Thank you all.